I'm very pleased to be invited to give one of this year's York talks. In fact, particularly because I'm very new at York, so it's a real privilege to be asked at this stage. And in fact, I haven't even made it to York yet. So because of the complications of coronavirus and the pandemic, I'm still here in the US, where I've been working for the last 15 years. But actually mention of the sort of disease, COVID, actually provides a little bit of a segue into talking about what I would like to discuss today, which is another disease, and that's actually malaria. So unlike COVID, however, which is directly transmitted, malaria is transmitted by a vector, by the bite of certain mosquitoes. And what I'd like to do is just give a little bit of an overview of some of the work that we've been involved with over the last 5 or so years, trying to develop a novel tool to help combat malaria and reduce transmission. So why malaria? Why do we care? Well, it's the most important vector-borne disease in terms of its impact on mortality and morbidity. So very impactful disease. Most recent data from the World Health Organization suggest around 230 million cases of malaria worldwide, resulting in over 400,000 deaths. That's a very big number, but just to sort of visualize that in some way, that's about twice the population of York dying from malaria every year. Something that maybe makes that even more tragic is that the majority of that malaria is in young children under the age of 5. Also, most of those malaria deaths, because it's a tropical disease and it interacts strongly with other environmental factors and socioeconomic factors like poverty, most of these deaths are in sub-Saharan Africa. So that sort of, because of malaria, but also some other diseases, that sort of actually gives mosquitoes the rather dubious distinction of being the world's deadliest animals. So more people die from the bite of a mosquito and the parasites and pathogens they transmit than any other animal worldwide. And it might be worth sort of bearing that in mind. Hopefully one day we'll be able to travel again, and we might be lucky enough to be in some nice tropical paradise swimming off the beach. And you might get a bit nervous about a shark attack or even a crocodile attack. But actually what you really need to be worried about is the bite from the mosquito at the barbecue that evening. So what can we do about it? Well, because it's a mosquito-borne disease, the best way of preventing transmission is to target the mosquito. And we have a number of tools that are very good at doing that. Those include, for example, insecticide-treated or insecticide-impregnated bed nets. So somebody sleeps under a bed net, the net itself provides a physical barrier, but the addition of the insecticide means that when a mosquito touches the net, it dies, and that stops it going on to bite someone who doesn't have a net, or come back the next day and bite you in the evening before you go to bed. We can also spray the inside of houses with insecticides, with long-lasting insecticides. And this kills the mosquitoes as they come into a house and feed and rest indoors. So both of those things really target the mosquito behavior, which is, for African malaria vectors at least, most of the transmission happens indoors and at night. So in this little cartoon here, we have someone sleeping in a house. They would be sleeping, giving off CO2, giving off heat. These are the major attractants that mosquitoes use to find their hosts. So these odors would be seeping out of the house through the gaps in the house. And many traditional African houses would have a gap between the top of the wall and the roof. So that would be the eaves. These are there for ventilation. So these odors would seep out, and the mosquitoes would then follow these odor cues and find their host. So what we've been interested in is whether we can sort of exploit that behavior and do something about it. Can we turn the house itself into a lure and kill device? And that's what our approach is based on. So that has two components. First is that we've tried to make the house more mosquito proof. So here you can see in this house, we've added screening to the windows, and you can see the cement line between the bricks and the roof where we've actually blocked in those open eaves. So we've tried to make the house more mosquito proof by providing this physical barrier. But just as with a bed net, that means that a mosquito that's probing, trying to get in, still might fly away and feed in the house next door or come back tomorrow. So we've also tried to add an insecticide, and we've done that through this novel approach called an Eve tube. And these are the tubes, these pieces of PVC pipe that we've added at Eve height. And these tubes act a bit like chimneys. So they funnel out the odors from people sleeping indoors at night, and they provide point sources that the mosquitoes recruit to. And rather than just being an open tube that a mosquito can fly into, we put inserts in place, and these inserts actually provide a physical barrier. They stop the mosquito going indoors, but they also allow us to treat the inserts with an insecticide. So just as the same with an insecticide treated bed net, as a mosquito contacts this insert, it picks up an insecticide and dies. And I'll come back to a little bit more later to talk about the insecticide delivery system. So what we've done is to try and turn the house into a lethal trap, attracting mosquitoes, stopping them getting in, and then killing them if they try and do so. And in our early research, we conducted a range of studies, small-scale studies and modeling studies to provide proof of principle that this was an interesting idea and could result in impacts on transmission. But of course, a definitive test is to scale that up and do that at village level. What we really wanted to demonstrate is that this could impact transmission at operational scales. So to do that, we moved to West Africa in Côte d'Ivoire. You can see it on the map here of Africa. And the reason, one of the reasons at least, we picked Côte d'Ivoire is that it has a very high disease burden. So if we can demonstrate an impact here, we can probably demonstrate an impact anywhere. So we worked with a range of partners, and the work was funded by the Gates Foundation. So we're very grateful to acknowledge their funding to support this very large field trial. So what we did was to come up to identify 40 villages. And so we worked in 40 villages, 20 villages received our intervention. So in the houses, we did screening and Eve tubes. And in the other houses, we had this as just our control. And we worked with a range of partners, and I'll go through this in a little more detail. That included partners from the National Institute of Public Health, from the London School of Hygiene and Tropical Medicine, so entomologists and epidemiologists, researchers at Penn State, which is where I was at the time, researchers from the London School of Tropical Medicine, and Intercare. Intercare are a small commercial company who produce this Eve tube technology. So we had this multidisciplinary, interdisciplinary approach to try and run this field trial. So just to elaborate a bit more on what that involved, we're working, as I said, in 40 villages. So we're going into people's villages and into their homes. And this is quite an intrusive technology. We're putting screening on their houses. We're drilling holes, putting holes in the walls. So we needed to have active community engagement and community participation. So we started with a whole range of town hall meetings, explaining what we were going to do, explaining this experiment, that it was going to run for 2 years, and we were going to be in these villages, in people's houses over this time frame. And there was pretty much unanimous support for the villages to participate in this experiment. So having got permission to do that, the next stage was implementation. So this involved going into, as I said, 20 of those villages to give the intervention. So there were about 8,000 houses in total, 55,000 inhabitants. So in just our treatment arm, we put in the treatment in about 3,000 houses. And that involved fitting screening, but also, as you can see here, drilling holes. And this is the rather clever apparatus that Intercare developed so that we could drill the holes in the walls to fit the Eve tubes. So this is what an Eve tube looks like from the outside. And you can see that this is the insert, and you might be able to see that it has sort of a white coating on it, and that's a powdered insecticide. So there's a rather clever bit of the invention here from Intercare, which is the netting is treated with an electrostatic coating, and that coating allows us to bind insecticide or powders to this netting. And so when a mosquito flies into the tube, brushes up against the insert, you get a transfer of powders onto the mosquito, and that leads to its death. And this is what one of the inserts or the tubes look like from the inside of the house. So you can see that it provides ventilation and acts as this sort of chimney to channel out those important host odors. And those inserts themselves, the insecticide wears off over time, so we can bring them back, we can wash them, as you can see here, and then retreat them with the insecticide and put them back out. So it's a relatively low-tech and relatively easy system to keep the coverage of the insecticide at high levels. So it took us about a year to put everything in place. So then, once we had the intervention in place, we needed to move on to the evaluation and monitoring. We had a number of key parts to that. First was epidemiology. So this involved recruiting 50 children from each village, so 2,000 children in total. And we had a team of nurses and clinicians, technicians as well, who would visit these children every 2 to 4 weeks over the whole study. So over the 4 years, that's about 30,000 child years worth of follow-up, massive effort. And these clinicians would, or nurses would give a little bit of a health check and then take a blood sample from the children, just a small blood spot. And we use that to determine whether the child has malaria parasites or not. So this regular monitoring allows us to look at the incidence of infection, the frequency with which children in these study villages are picking up malaria parasites. We also then, as I said at the beginning, this is a mosquito-borne disease, so we also monitored the mosquitoes. We did this in a number of ways, but the sort of most effective way of doing this is with human landing catches. So we had a team of about 800 volunteers in the villages sampling mosquitoes overnight, and what this involves is basically rolling up your trousers and using a flashlight and picking off every mosquito that lands on your lower leg as it arrives. So this gives us a very direct measure of the biting pressure. How many bites would a person likely receive overnight, comparing both indoors and outdoors, comparing our study villages, our treatment villages with our control villages. So we collected over 250,000 mosquitoes across the whole 2 years. 210,000 of those were malaria vectors identified to species. And about 120,000 of those were then subsequently dissected so that we could determine whether they had malaria parasites or not. We also did a lot of social science work. As I said, this is quite an invasive technology. We're going to people's homes, we're disrupting their homes, and we're following their children. So there was a big component of social science, interviewing individual householders, and various focus groups to get a sense of what people thought of this intervention. Were they happy with it? Did they like it? Did they think it provided a benefit? And that took us 2 years to monitor all of that. And then we had about another year to do a preliminary analysis of the data. And what I'm excited to share with you today is the results of that first big analysis. We have many more data to look at, more analyses to do, but this is the sort of big picture result. It's really exciting that what we found is that with the epidemiology, we had an approximately 40% reduction in the risk of malaria in our study children. That means children living in our treatment villages were 40% less likely to pick up malaria parasites than those children living in the control villages. That's also then reflected in the mosquitoes. So we had about a 60 to 70% reduction in the probability of being bitten by an infectious mosquito. Now, those numbers might not sound very big, but they are substantial reductions in the force of infection or in the burden of malaria. And importantly, they are on top of the use of insecticide-treated nets. So at the start of the study, in all of the houses, we gave out bed nets. So that's the current frontline intervention. And what we've done is to add to that a further 40% reduction in malaria or 60 to 70% reduction in being bitten by an infectious mosquito. The social science work indicated that householders really like this intervention. About greater than 90% of the householders say they'd be happy to keep this intervention. We also did economic analysis, and it showed that this was a cost-effective intervention. So the cost effectiveness was in the same ballpark as indoor residual spraying with insecticides. So we're really excited that we've done this massive amount of work, really big study, bringing together social scientists, epidemiologists, entomologists, business partners, to actually evaluate this tool. And what we've come up with is a new tool which adds to control above and beyond bed nets and is apparently cost effective, and people like it. So that sort of brings us to where I am now, which is a new position at the York Environmental Sustainability Institute. And I think what's nice is that what I hope is that what I've just talked about with that example from the malaria work provides a really nice illustration of the importance of interdisciplinary approaches. If we'd simply done the entomology, we wouldn't then know, well, did it impact on disease transmission? So we did the epidemiology. But then even if we'd done that, well, do people like it? So we did the social sciences. And even if we did that, well, was it cost effective? So we did the health economics. And so we then came up with a very promising tool, but how are we going to implement it? So we have commercial partners that can do that. And it's this interdisciplinary approach, which is very much embodied in the York Environmental Sustainability Institute, trying to develop large-scale research projects of with interdisciplinary partners to tackle the major challenges of food sustainability, ecosystem resilience, and the interaction between humans and their environment, and ultimately the human health and well-being. So I'm very excited moving forward to sort of bring this experience and to participate with YESI, developing more projects that really reflect this interdisciplinary approach. And with that, I'd just like to sort of return the final acknowledgement slide of the various partners in the malaria work that I talked about. This is just a number of the key names, key players, but there were many, many more people involved. It was a very large collaborative effort. And with that, I would thank you very much for your attention.